Well, it's obviously impossible to cover in 50, 55 minutes the whole topic of prosthetic valve evaluation, so I'll do my best. So there's a lot of valves, so I'm not going to go through every single one of them. I think we know most of them by prosthetic valve, mechanical valve. Obviously, now we have all the percutaneous valve, so we just have to keep reading and learn about the new valves, but we're going to talk about most commonly implanted valves. Okay, so this is the most important, one of the most important slides, I think. Whenever we evaluate a patient with prosthetic valve with imaging, the most important information we try to get, this also for the sonographer and the fellows, is when the valve is placed, if it's possible, as much information as we can about the details and circumstances. Excuse me. About if the root was enlarged, what kind of graft, conduit type of, and size of prosthetic valve, and other clinical information that we need to collect is the height, body surface area, symptoms, clinical finding, and importantly, blood pressure and heart rate. So when we have all those clinical information and we focus on the valve, first we do 2D imagings, look at the motion of the leaflets or occluder. For bioprosthetic valve, you need to pay attention, just like a native valve, presence of calcification in the leaflet, any abnormal echo densities, and every components of the prosthesis. And then you look outside the leaflet, look at the sewing ring integrity and motions. So that's the imaging of the valve. And obviously, the clue about a prosthetic valve dysfunction oftentimes can only be seen by the consequences in the cardiac chamber. So it's very important to look at the chamber size with 2D and then Doppler information that we're going to show later on. And importantly, we have to compare to the prior studies. So this is a guideline from American Society of Echo about evaluation of prosthetic valve dysfunction, chaired by Dr. Zogby, almost 10 years ago. It contains, I think, most of the all the information you probably need to know for basic evaluation of the common types of surgical prosthetic valve. So let's go through aortic valve real quick. This is a common finding. Patient come here with a very high gradient across the prosthetic aortic valve, in this case, doing a TEE. So the differential in someone who has a prosthetic aortic valve and a very high gradient is either is a patient prosthesis mismatch. Remember, all the prosthesis, surgically planted, is inherently obstructive. Second common causes could be high flow due to anemia, sepsis, regurgitation. Excuse me. Hello? 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 Yeah, it's a lab. I'm sorry, I'm covering a CT lab and they're busy. And obviously, we worry about obstruction could be due to leaflet degeneration, clot, pannus, or abscess obstruction. So what are the clues for prosthetic patient mismatch? Usually happens in small patient with small aortic annular size, and the replacement is due to aortic stenosis. Oftentimes patients don't really improve after the surgery, and there's no reverse remodeling, meaning the LV remain hypertrophy. And this is a good example, rare, but could happen. You can see the pre-op and post-op, the gradient is almost the same. Patient had a very small prosthetic aortic valve placed, so patient obviously would not improve with the valve replacement. However, most of the time you can differentiate normal versus obstructive valve, and with close examination of the aortic valve's continuous wave signal. This is a study done by Sagir when she was here almost over 5 years ago, and this is published in JACC Imaging from our lab, that thing you look for is the acceleration time. You can look at the left-hand side. The normal one is nice, early peaking, and the obstructive one is rounded. So the acceleration time is prolonged in patient with obstructive valve. And the ratio between the acceleration time and ejection time is also prolonged. And when they look at, in this cohort, I think close to 100 patients, the best diagnostic accuracy for separating patient prosthesis mismatch and obstruction acceleration time with almost 100% specificity for prosthetic valve stenosis if the acceleration time is over 128 milliseconds. So this is kind of a summary for you to put in when you read in the reading room. So when you have a prosthetic valve, jet velocity over 3 meters per second, first you check the DVI, the Doppler velocity index that we all know, velocity between the LVOT and the aortic valve. And we know that if it's over 0.3, a jet contour is normal, meaning that it's less than 100 milliseconds, and then this valve is okay. And could be likely there's no obstruction, could be due to high flow of patient prosthesis mismatch. And if the DVI is high and acceleration time is prolonged, then you have to consider stenosis due to subvalvular narrowing or underestimation of gradient, or this is very commonly improper or incorrect LVOT velocity sampling. But if you have a kind of borderline DVI, I think the acceleration time is very useful. If it's over 100 milliseconds, it's strongly suggestive of prosthetic valve stenosis, and obviously the diagnosis should be confirmed by either TEE or other imaging technique, like CT or MRI. Okay, paravalvular regurgitation. I'm going to focus mostly at the TAVR because that's kind of like what we eventually, for aortic valve, that will be the predominant valve rather than surgical valve. As you can see there, oftentimes the valvular leak is very eccentric. It's key to have a short axis view to measure the circumference involvement. This is an example taken out from the latest guideline for assessment of percutaneous valve by American Association of Society of Echo, again chaired by Dr. Zogby. As you can see here, oftentimes the prosthesis cause artifact attenuation in the posterior aspect, and since this jet are very eccentric, this is the two cases here. This patient who had one jet only. This patient actually had two jet, and you actually can only find out when they went to a deep transgastric view. So the key is this jet is very usually eccentric. You need to really do a good job and scanning through the entire prosthetic valve, oftentimes a different unusual angle. Again, this is a guideline, and I confess I haven't read the entirety. I read the first portion of aortic valve, but it's very well written documents. And this is kind of like a run through when we assess a patient with suspected aortic regurgitation or with aortic regurgitation after a TAVR. So for the guideline, on experience is 2D, contour and the shape of the prosthesis usually is not very helpful. So the key is to go through in a short axis view of the aortic valve, find out where the jet is, and hopefully, ideally with 2D, with 3D TEE explain, you can measure, kind of capture the jet, and find out the vena contracta, okay? and then the circumferences, percentage of circumferences involved of the jet. And obviously, if you have a proximal flow conversion, like show here, like a pizza, this usually means it's a significant regurgitation. And if you have flow reversal in the descending aorta, is another sign. And in transthoracic, if you have pressure half time, aortic regurgitation signal, short pressure half time is another sign of severe AI. And obviously, you can calculate the difference between the output from differential output between LVOT and RVOT. So the guideline recommend the classification of the different severity of aortic regurgitation based on vena contractile area and percent of circumference involved. And this is a kind of a run through. Obviously, don't have time to go through every single detail, so I strongly recommend you download the documents and read carefully, but basically include the thing we just talked about. Okay, how about mitral valve? The essential thing about assessment of prosthetic mitral valve is, number one, obviously, the velocity, and when it's more than 2 meters, is considered abnormal, but remember, it's very flow dependent. And the mean gradient should be most of the time less than 5, but again, we know the gradient is related to the heart rate. We usually try to calculate effective aortic area. You can do pressure half time in the absence of left heart disease or aortic valve disorder. Same pitfall with a native valve assessment, or we can calculate the effective aortic area by continuity equation in the absence of significant aortic mitral regurgitation. And then we look at any regurgitating jet, and of course, the hemodynamic consequences of the lesion in the chamber size and pulmonary artery pressure. So for normal prosthetic valve in the left-hand side, usually a peak velocity less than 2 meters per second, mean gradient less than 5, and you can see the by pressure half time. In this case, patient did not have any left ventricular dysfunction. The valve area was 2.2, and the right-hand side, as you can see, the peak velocity is much higher, 2.5 with high mean gradient, and that's definitely is an abnormal valve. So the cause of high gradient could be due to obstruction or regurgitation. So this is study done almost over 15 years ago, published in AJC 2002 from our lab again. There's several transthoracic Doppler index which could point to what type of pathology is causing the high gradient. So if you have peak velocity over 2 meters, the TVI ratio between the mitral valve and LVOT more than 2.2, that usually end at a pressure half time over 130. So if you have pressure half time more than 130, most likely it's stenosis. And if it's less than 130, usually it's regurgitation, okay? But overall, the Doppler evidence for severe MR is you have high E velocity because of the large flow going through, and the ratio between the TVI through the mitral valve and LVOT is gonna be very elevated, okay? And usually the pressure half time is normal, and you have very dense MR jet by CW or early peaking, and you can calculate the regurgitation fraction by the difference between the left ventricular stroke volume minus the LVOT flow, similar to what we do with in the native valve. So next is when you have obstruction, the etiology, okay? It's caused by either thrombus or pannus. Left-hand side is an example of thrombus, and the right-hand side is example of pannus. So how do we know which one is which? Because they kind of look similar. And this, again, studied from our lab a long time ago, over 20 years ago. So size matter. If the length and area is large, most likely clot is bigger than Panus, and the video intensity ratio is a little bit higher with Panus and lower with thrombus. Kind of, when we do CT, it's kind of similar to what we observe in CT. Okay, and so this is again the sensitivity and specificity of the different echo parameter. But one of the most important thing is about level of anticoagulation. If the patient is not adequately anticoagulated, most likely is due to thrombus. Okay, so this is a case, the patient who got pre and post lysis, a mitral valve clot, and TE does help us improve the assessment of thrombolytic therapy in patient with obstruction. Okay, so what do I mean by that? If you have a large thrombus burden, in this case more than 1.6, the risk of complication with thrombolytic is very high. You can imagine you have a large thrombus burden, you start breaking it out, and it's something going to cause embolization. And that plus the valve area and history of stroke, if you have both large thrombus burden and history of stroke, you can see the complication and death rate is very high. We're talking about almost everybody had a complication. But if the clot burden is small and there's no history of stroke, the prognosis is much better. This is a very interesting study because it's a multi-center registry done long time ago, again, over 15, 20 years ago. And I think Dr. Little has presented multiple times about the role of 3D echo for assessment of prosthetic valve. I think we all know for the fellow, this is a given. It's a no-brainer that with 3D DE really, really present a huge advances for us in terms of assessment and also guidance of the therapy of a patient with prosthetic valve, especially in the mitral position. So TE allow you to assess the actual orifice area. It can better assess the etiology of the gradient, better quantification using vena contracta area, and again, I mentioned guiding therapy. We all know the 2D TE is hard to quantify. Obviously, we can get a sense of if it's severe or not so severe, but the quantification is a little bit harder. And in 3D TE does provide you a little bit better, especially for vena contracta area, I think is useful. And in this case, as I mentioned, in mitral position, 3D TE is really, I would say, spectacular images that you can obtain. And you can, against the cath lab guide the interventional cardiology to place the catheter, place the occluder, like this case, with a very large paravalvular leak and the placement of the PDA occluder in the defect. Okay. All right, but obviously, TE and transthoracic have some limitation. I'm not gonna go through, you all know about the problem of acoustic shadowing, and if you're not aligned well, you can underestimate the true velocity. That's why CT and MRI come in, and the advantage of CT and MRI versus TE is obviously less artifact. We can assess the entirety of the prosthesis, the cardiac structure, the extracardiac structure, the coronary, allows a unlimited view, 3D rendering, and MRI offer superb, more, I think, accurate quantification of severity of lesion. And in certain type of prosthesis can help, it's very useful to help us localize the origin of the regurgitating lesion. So just a quick case, a patient with a prosthetic valve come in with the shorter breath. You can see the echo, not unusual, kind of like, you know. Yes. The prosthetic valve, but Doppler is very useful, very high velocity, near 4 meters, and DVI was low, so there was suspicion of aortic valves high stenosis due to obstruction. So TE was performed. Again, we know there is a prosthetic valve here. There is some aortic regurgitation, probably paravalvular, but it's hard to know what. So we know that probably an obstruction, but it's hard for us to tell what's etiology, what caused the obstruction. And so again, that was so CT, I think, is probably the best technology that we have right now in looking into the etiology of the obstructive prosthetic aortic valve. As in this case here, you can see a very small amount of low attenuation underneath the valve, and this is gated CT. You can see the leaflets are barely opening. This is the 3D rendering of the valve. As you can see, this is completely immobilized, and these are very limited excursion. So no question, there's something impinging the leaflet, preventing from opening, and judging from the location, subvalvular, not a big amount of tissues and low density, so most likely it was pannus, and it was confirmed by the surgical pathology. And this is another case. I think a lot of fellows saw this one. It's a lady with prosthetic aortic valve again. I'm not gonna go through again. Transthoracic diagnosis. There's a prosthetic valve obstruction with some degree of regurgitation. And TE, again, suffered the same limitation. We have the acoustic shadowing, and CT was very useful. There was 2 area of abnormality with slightly differential attenuation factor. One is around 50, the other one was 70, and also the location help us. One is subvalvular, one is not supravalvular, but in the aortic side of the leaflet. You can see right here. One is right on top of the leaflet, one is underneath. So the one on top had a lower density, the one underneath has higher density. So Dr. Mimir actually read this one, and as you're not surprised, he got it right. He thinks there's a clot and there's a pannus. We don't, this is just pretty, so I have to put it there. Okay, I don't know why. All right, so she was starting heparin and then lytics because things didn't get better with heparin. So she got better. Peak velocity went from 5 meters to 2.5 meters. And you can see the one on top went away. That's probably clot. The one underneath is still there, preventing from this leaflet from opening. I think this is one of the best case we've ever seen. Word of caution, not all the CT is this quality. Like echo, like any imaging modality, if you don't get good contrast down there, diagnosis is not that easy. But if you have, most of the time we can get similar quality imaging, and this case is, I would say, one of the best we've seen. Again, this is just for bioprosthetic valve. If you have degeneration, remember, fellows, if you suspect a bioprosthesis degeneration with obstruction, always get a non-contrast, okay? Because once you give contrast, it will be hard for you to detect any degeneration, for instance, calcification. You want to look as not, in this case is out of the world because this is a really, really, really degenerated bioprosthetic valve, tricuspid valve. And this is it's a very weird case, a patient with high gradient almost in 4 days after redo AVR, and is a defective valve from the manufacturer, so that's a zebra. And you can see pannus and bioprosthetic valve. This is very thickened, and there's not much calcium, so most likely it's not due to degeneration, but inflammatory reactive tissue due to pannus. How about for TAVR, we all heard about this subclinical leaflet thrombosis, and CT we're seeing more and more. This patient with, for instance, again, the location of very low attenuation in the aortic side of the leaflet. And so, again, this is a 3D rendering of the clot here in multiple sinus, okay, very large clot burden. And this is one of the kind of unique case of a TMVR, okay? Again, this is 2 years, I believe, after the implantation. So patient presented with high-grade necrosis mitral valve, and you can see that there's 2 leaflet here. There's a large clot burden, and this is not as much. And again, this is, again, quite a, going back to what I mentioned earlier, this is unusual. One of the, I think, first case we saw of degeneration of the TAVR, I'm sorry for the wrong spelling. As you can see, if you do a non-contrast study, you've seen all this calcification and thickening of the leaflet. This is a patient, I think, 2 years post-TAVR, and he's a patient in renal, end-stage renal disease and dialysis, so has a risk factor. But it's unusual. We haven't seen that many of these cases. So for obstructive lesion, CT is very useful. You can measure anatomic orifice area. You can assess the leaflet motion and opening angle. And importantly, you can assess the etiology of obstruction. Endocarditis, I think we covered that last time. Steve showed. But again, CT is very useful, especially when you suspect complication like fistula or abscess formation, like this patient with endocarditis, a prosthetic valve, causing obstruction, high gradient. And the interesting thing here is there's a TE, there's a EO-identified colored jet, which, during TE was quite sure where it's leading. And CT, indicated CT, you can see there's a suspicion, or I think quite convincing that there's a fistula between the LVOT and the right atrium. You can see doing diastole is not as prominent, doing systole is a little bit more prominent. So it's confirmed, it was confirmed in the OR the patient did have a fistula.
So,
yes.
Quick question. I think the data is very convincing that for obstructed aortic valve, particularly mechanic, CT is the way to go, and we should even skip a TE altogether, unless there are other reasons for the TE. Question is for the obstructed mitral. Do we have enough data to say that also with a mechanical mitral, you might do a better job differentiating clot and panus from, than what TE can do? Because again, for the patient, if that's the case, we should either one of the two just go straight to CT and do not do a TE. So do we have enough data on the obstructed mitral?
I'll show you some data, some very limited.
Okay.
Yeah. So regurgitant lesion, again, this is just some show and tells of, dramatic cases of paravalvular dehiscence that we can see. But I think one thing that I want to bring this special attention to when we encounter cases of patient with mitral regurgitation and has a surgical ring put in, and the patient end up with mitral annulus, the surgical ring dehisce, all right? Sometimes we call it paravalvular leak, but that's truly not the case because the regurgitation is from the original regurgitation. It's not leaking. The regurgitation is not due to the dehiscence because, the ring didn't work, and we had a beautiful case. I should have put it there, patient with a posterior infarction, a huge aneurysm. So it was a ischemic MR, and they put a ring, and 2 years later, you can see during CT, the posterior wall is being pushed out during systole, and that's the area where the ring dehisces. So the regurgitation is still the original regurgitation. It just happened to go around the ring. So the treatment is not plugging the defect, because you're not going to fix anything. The treatment is put a mitral clip. So for us, it's very important when you comments, and it's not a paravalvular leak. Okay, it's the adhesions of the ring, but the regurgitation is valvular. So this is a small study we did, and we tried our best, and we collected, about close to 30 cases of redo valve surgery. Every patient has surgical confirmation, and so bottom line is this is what we found, that obviously is a tremendous bias here. This patient all went to the OR. We know from the echo was done first, and CT was done either for a coronary assessment or for clarification of the prosthetic valve dysfunction. So again, very, a lot of bias here. But bottom line, what we found is both TE and CT are very good in identifying, it's either it's obstruction or regurgitation. And CT was better in identifying, as Dr. Q very astutely mentioned, confirmed what he suspected from clinical observation, is the etiology of obstruction lesion transthoracic, the CT was better than TEE. However, for mitral valve, we don't have that many cases of mitral valve, because I believe, because most of the time it wasn't needed, because 3D TEE for the mitral valve obstruction is very good. It's very good. So, and but obviously CT offer you all this extra information. So the question is, do you do CT first? If you have question, then do the TE for mitral valve. But I think at this stage, I think TE with 3D TE is really way to go. And our study was included in this just recently published meta-analysis of diagnostic value advanced imaging modality. I mean, it's amazing that these people from Korea went through the entire PubMed, and they found like 17 studies, and the total number of patients was 229. And we contributed 10% from this hospital. So no surprise, 3D TE, and so they did analysis between 3D and 2D TE. So no surprise, 3D TE and CT was better than transthoracic and 2D TE, and is better for prosthetic valve obstruction. So kind of similar finding.
It's still a biased study because the meta-analysis, because everything that was included were studies showing that 3D TE, say, and CT added incremental information to TE.
It's definitely publication bias,
Had it been any different, these actual original manuscripts, to sort of not confuse them with the meta-analysis, would not have been published.
Yeah, and they're all mostly case series.
Yeah.
They're all case series, actually. Yeah. So do you want to go through this? Or oh, yeah. So that's all I have for CT, and Dipan is going to show some.
Okay. Terry, can you guys put me the laptop live? Laptop? Okay, thanks. Is it just as simple as this? No. I think it's, let's try Podium VGA. Okay, there we go. Nope, not quite the right mode. So I gotta switch this around. We don't want this. Do you know how I can switch the two? Oh, there we go. Okay. So obviously the first thing, and I think this is not news to anyone here, but I want to make sure for the audience that's streaming in live, that if you're using MRI, remember always that the MRI scanner is always on. And so I think one of the concerns that came about was, are these prosthetic valves in fact safe to even go into an MRI scanner? So fortunately now over the years, we've had a fair bit of data that have kind of looked at this. And I think probably the most robust was this study where they looked at tissue samples that were excised at the time of heart valve replacement surgery for patients that were getting redo surgeries, and really found that the likelihood that any of these prosthetic valves would actually get dehisced by pulling out out the suture in a magnetic field was not really a concern, even up to 4.7 Tesla. So fortunately, since everything we do right now is at 1.5 and 3T, clinically, that's not going to be an issue. Now, obviously, we don't know about the 7 Tesla scanner that we have coming down the road. We don't know if these are safe yet for that or not. Now, one thing, though, that is a concern with MRI, not so much from a safety standpoint, but from the standpoint of imaging artifact. And so with metallic valves, it's variable from individual valve, but there can be significant imaging artifact for some of these mechanical valves. And so that's one of the things I think you certainly need to be aware of and be cautious of as well. So because of these limitations as far as artifact, that can then make it challenging to be able to assess transvalvular velocities in the setting of mechanical valves, because you really need to be able to image at the location of the valve itself to calculate velocities. Now, bioprosthetic valves, on the other hand, generally speaking, the artifact is much more limited, and therefore the artifact is really fairly manageable by MRI. There's some exceptions to that, and we've seen some bioprosthetic valves that in fact will cause a pretty significant metallic artifact, but fortunately that's fairly rare and fairly uncommon. So what I'm going to try to do here is talk to you a little bit about how CMR could help, and really it's in these kind of 3 or 4 scenarios that I want to touch on. One is for bioprosthetic valve stenosis, and again, as I mentioned, for mechanical valves, if you're looking for stenosis, CMR is not really going to be the test of choice. The other is if you're looking for aortic prosthesis regurgitation or mitral prosthesis regurgitation, that's an area where CMR can help. And then I'm going to talk about endocarditis, and what CMR can and also cannot do in the setting of endocarditis. So obviously, just like we do with native valves, when we're trying to assess for valvular stenosis, there's really 2 pieces of data that are independent of each other that we're trying to obtain. One is to determine what is the peak velocity, the transvalvular velocity across a valve, and that's done using this phase contrast CMR technique, where we'll position the sequence perpendicular to the level of the valve itself, or a little bit above the valve. And then from that, we're able to ascertain what the peak transvalvular velocity is across this lesion. And so this works well for both native valves, and as I'll show you, there's some data that also supports its use in bioprosthetic valves as well. The other piece of data that we'll get, and again, this is completely independent, so this is not a derived measurement based on the transvalvular velocity data. Rather, it's directly imaging the valve and trying to determine what the anatomic orifice area is. And that's typically done using a series of these, what we call phase contrast sequences, to try to identify the narrowest opening and then basically perimeter the valve area there to determine the anatomic valve area. Now, let me go through one study. This came out a few years ago. This was from here. And this was looking at patients with bioprosthetic valves and trying to compare how CMR did with echo. And so in addition to doing assessment of anatomic valve area, in this study, what was also done, in fact, was an attempt was made to derive an effective orifice area using a methodology similar to what's used in echocardiography, where essentially we're performing a phase contrast technique at the valve leaflet tips to derive what the transvalvular velocity profile looks like. And then if we, instead of taking the peak velocity only, if we actually take the curve of the peak velocity at every single phase in the cardiac cycle, integrate this area together, we can essentially derive what's kind of equivalent to what's derived in echo when they talk about a VTI. And then if the same thing can be done for a measure of systemic flow at a non-stenotic area, so in this particular series, it was done actually above the valve level in the mid-ascending aorta. I would probably say now it might be even better to do it in the subvalvular area, so the LVOT measurement. And again, take the peak velocity, integrate the area of the curve, and then from that, you're able to actually generate a ratio, a Doppler or LVOT to aortic velocity ratio, essentially, which then can be multiplied by the area of whatever structure it is at the location where you're doing your reference measurement to then determine a effective orifice area. And in this study, there was a fairly good relationship, in fact, between the effective orifice area derived by phase contrast CMR versus the effective orifice area derived by Doppler echocardiography. And the Bland-Altman plots over here show really that the 95% confidence intervals are within about 0.25 centimeters square. So let's move on now to non-stenotic lesions, and really so regurgent lesions and how CMR can be used in these settings. So again, the way that we would derive, for example, an aortic regurgitant fraction or regurgitant volume in a native valve is by measuring the flow distal to or above the valve level. And what we're interested in is actually measuring the direct column of blood that's coming backward, the retrograde reverse aortic regurgitation flow. And in bioprosthetic valves, you can essentially do the exact same thing. Now, you need to make sure that you're high up enough. So here's an example, in this case, of a TAVR valve. In addition to the kind of the standard long axis views that we have, as well as this LVOT coronal cine view and a phase contrast view that we have in the LVOT, where we can see in diastole that there clearly is a regurgitant jet. The way that we would actually try to determine the magnitude is really one, by placing a phase contrast sequence above the valve level to make sure that you're clear of any of the metallic artifact from the prosthetic valve or the percutaneous valve itself, and then actually derive a direct reverse flow in diastole. And that can be a manifestation of what your aortic regurgitant volume is. Now, other checks that are typically done in addition to this is also to look for holodiastolic flow reversal of a reasonable magnitude in the descending aorta as well, similar to what's done in echocardiography. And in the CMR literature, the goal is to see at least 10 cc's of holodiastolic flow reversal in the descending thoracic aorta. As we can see in this example case here. And then in addition to that, we'll do the other confirmatory checks by saying, let's actually measure the forward flow going out the LVOT, so proximal to the percutaneous valve, and then compare that to what the flow is in the PA, the net pulmonary artery flow. And in this case also, that came out to about 50 cc's. So we've got multiple pieces of data that are all concordant. And in this patient, we really determined that there's about a 50 cc aortic regurgitant volume and a 50% regurgitant fraction in this percutaneously placed aortic valve. And this was a patient who had presented with obviously heart failure symptoms, went on to the cath lab again, and then this was just a confirmatory aortogram that was done that shows, in fact, significant aortic regurgitation. This patient was at 6 weeks post-TAVR, went on to get a redo TAVR valve, and then clinically was doing quite well in follow-up. Now, there's actually a large series, about 150 patients or so from a Canadian group that published on what is the prognostic significance of paravalvular aortic regurgitation as assessed by CMR. And in this study, what they're able to demonstrate really is that whether you look at all-cause mortality or a combined endpoint of all-cause mortality and hospitalization for heart failure, there's significant separation between those patients who had mild aortic regurgitation by CMR and those who had moderate or severe regurgitation by CMR, again, defined here as greater than 30% regurgitant fraction. A couple of interesting kind of caveats from this study. One was that there was a stepwise worsening in clinical outcomes with increasing severity of regurgitant fraction. But interestingly, not with increasing regurgitant volume alone. There was worse outcome, obviously, with regurgitant fraction more than 30%. No association between regurgitant volume and clinical outcomes. And then this may be actually due to several reasons. One is that if you think about it in these post-percutaneous valves, the underlying disease that these patients had was actually aortic stenosis. So you have a ventricle that's probably stiff and hypertrophied. And this may be much more analogous to dealing with an acute form of AR, where you've got a ventricle that's not really adapted, and you've gone from maybe no AI to all of a sudden a significant amount of AI. The fact also that these are ventricles that are underlying aortic stenosis and may have significant remodeling of the ventricle before they underwent their procedure. And then lastly, obviously, in the setting in this setting with these small ventricles, the total stroke volume of the ventricle may be reduced or may be small. And as a result, regurgitant volume in and of itself may not be as good of a predictor as fraction, which really integrates the amount of regurgitant volume based on the total output of this ventricle. Now, what about for mitral regurgitation? So again, the standard method that we do for native valves is this methodology here, where we basically obtain the LV stroke volume by planimetering the end diastolic and end systolic volume, and then compare that to the forward flow across the aortic valve. And then this, in fact, is the same methodology that we would utilize in prosthetic valves as well. And let me just show you an example case here of somebody who has a mitral bioprosthesis. And any of the fellows want to, just going through these images real quickly here, tell me what you see? And maybe what I'll do is I'll show you the long axis interrogation. So what we've done here is really a series of 3-chamber views going anterior to inferior to encompass the entire left ventricle. And so I'm just going to go through these one by one. Was that? Yeah, so this is an interesting kind of repair that was done, which we don't see very often here at least. This was an outside repair where they left the native leaflets intact and just put in an annuloplasty ring. And that's what you're seeing there. What do you think about this annuloplasty ring? It's dis, right? So, in fact, and you can see, I think this view shows it very nicely, that there actually is a posteriorly directed jet of regurgitation. So in this case, again, the way that we're going to try to quantify, so once we've localized there's an abnormality here, or even if you haven't been able to localize it, when you go to your quantification, you're going to notice a discrepancy in numbers, which is the LV stroke volume by comparing the end diastolic and end systolic volume is 157 cc's. But the aortic forward flow is only 82 cc's. So you've got a big difference between what this ventricle is squeezing out compared to what's actually being ejected out forward across the aortic valve. And therefore, in the absence of a ventricular septal defect, this is blood that's going actually retrograde back into the left atrium, and this is your effective mitral regurgitation. So in this case, 75 cc's of mitral regurgitation, severe MR. Now, what about endocarditis? So probably the one message I want people to leave home with is, when you're talking about small, highly mobile, randomly mobile structures, CMR is not going to be a good technique for identification of vegetation. Now, there are cases where you can see it, but there's going to be many cases where there could be a vegetation that you just will not be able to identify or detect. And so as a result, if your question is, does this patient have endocarditis or not, that's really not an appropriate referral for CMR. Now, if your question is, this patient has endocarditis, I want to know what the severity of the regurgitation is, that is an appropriate indication, and CMR can be helpful. Now, another scenario in endocarditis where I think CMR could be helpful as well is this example that's shown here. And let's scroll down again to the long axis views. And I think things will become much more apparent as we get to the 3-chamber view. So you can see there's a prosthetic valve in the aortic position. And what do you notice here? So do you see an attachment between the valve and the intervalvular fibrosa area? The aortic annulus, right? There is none. And you can see this valve actually has a little bit of a rocking motion to it as well, right? So this is partial dehiscence of the aortic prosthesis. And so with CMR, not only can we, are we able to localize or identify this abnormality, but you can also do, let me go back here for a second, an interrogation of the entire chest to localize exactly how far this abnormality goes. Is it just localized to the direct sewing area, or is it actually extending further up? And I think there's actually a very nice angiogram which shows it. Let me see, here we go. And you can see, if this will play, that not only is there this big, huge pseudoangiogram cavity, it actually tracks way up along the aorta superiorly as well. So again, this can help in identifying, obviously, that there is a pseudoaneurysm, but also in identifying, what type of surgical approach needs to be done or cannot be done. So let me go back to continue on with my slides here. And then to just wrap up, so to wrap up, when is CMR not optimal? When we're talking about prosthetic valves, I think if you're looking for vegetation, and also if your interest is in trying to identify mechanical or transcatheter valve gradients, so looking for stenosis within transcatheter mechanical valves. But it is useful if you're trying to identify bioprosthetic valve stenosis, or if your interest is in looking for regurgitation, either to mechanical, bioprosthetic, or transcatheter valves. Thank you for your attention. Oh, sorry, forgot. This is the final take-home slide, so hold your applause. And this is actually something that Dr. Chang and I put together when we did a grand rounds last year, which is to say this is kind of a proposed algorithm for how you would approach patients with clinically suspected prosthetic valve dysfunction. And I think obviously the Twitter people like to they've taken the hashtag echo first, so I guess we got to put echo first in the algorithm here. Although again, this may be one that's in evolution. I think if your question is about obstruction, that's where potentially CT may be the best test, especially if it's for the aortic valve, as we talked about. Other options could be 3D transesophageal echo, and then CMR could be helpful, but only really in bioprosthetic valves. If your question is about regurgitation, that's where I think either 3D TE or CMR could be very useful, and then MDCT could be useful if you're trying to plan for a percutaneous repair. And then obviously for endocarditis, really there's not a role for CMR or even CT in really diagnosing endocarditis. That's really where you want to move on to echo, potentially with transesophageal 3D echo. And then this is an area where I think hopefully more data will emerge for the potential role of PET to help in identification of endocarditis and complications as well. But I think where the advanced imaging modalities clearly can be helpful is not so much in diagnosing endocarditis, but looking for the complications of endocarditis. So now you can applaud. Thank you very much to Dr. Chang. Any questions at all? It's all straightforward? Yeah, Rusha.
If after doing TEE, there's still somebody's not, if after doing a TEE, somebody's still not comfortable ruling out endocarditis, would it be recommended to repeat a TEE in a little bit or do a CT or CMR?
Okay.
And we get that quite often in terms of referrals.
I think it depends on the mitral valve is very unusual that you cannot have a diagnosis unless you have a lot of artifacts. Aortic valve is a little bit different. Problem, if you don't see with a reasonable, good quality TEE, the vegetation is probably not very big. In that case, unless you have a really, really, really superb quality, image quality CT, we can get a lot of contrast down where the prosthesis is and slow heart rate. It could be And obviously, if there's concern of any abscess, especially because fistula, color Doppler is really the one who make the real difference. I mean, truly. I think MRI is the same. I think the main advantage of MRI is to look at, the direction, location, and if there's any abnormal jet. I don't know how good is the resolution in terms of the jet size for you to pick up some.
Yeah, no, you don't, I mean, you don't have, yeah, I mean, maybe in the future, there's, where you talk about, 4D flow techniques and things like that. But none of those techniques have the resolution that you have with transesophageal echo. So, I mean, maybe Moaz commented, I don't know if, in those cases where there's an index of suspicion for endocarditis, but your initial transesophageal echo is negative, is there a role for PET in that setting?
Yeah, I mean, for prosthetics, yeah, this is where, for prosthetic valves, this is where PET could help, as we reviewed like a few weeks ago. The only caveat here is like not in the very early phase where there is some conflicting data right now, and the guidelines kind of say it has to be after 3 months of implantation. Some sites have been trying earlier, so if it is positive, it may not help you, but if it is negative, then you are sure there's nothing there.
Good. Okay, well, thank you all for your attention.
You.